Right, everyone. As it is 7:30, I'll start our Grand Round lecture. Um, Good morning, and thank you for attending our Grand Round lecture. Associate Professor in the Division of Medicine, joining summer 2024 from LSU Health Sciences Center in New Orleans. His expertise focuses on HIV management, particularly renal and cardiovascular comorbidities, clinical trials for new HIV therapies. He has been advocating on HIV. Before medicine, he worked as an epidemiologist in NIC's Department of Health, specializing in HIV surveillance and epidemiology. We are very grateful for Dr. Bennani's expertise in infectious disease and cardiovascular risk, and look forward to the insight he will share with us. At the end of the lecture, we'll leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and end of the presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I'll now turn it over to Dr. Bennani.
Thank you. It's great to be with you all. It's great to be at VCU. And I'm looking forward to talking to you about this today. There is the signal is breaking up a little bit there, so I hope that wasn't on my end. I hope I don't lose you guys. There is some thunder and lightning outside over here, but I'm just going to jump in. We have a lot of ground to cover. So I'm going to be talking about infectious diseases and cardiovascular risk. This is a topic that has come up a lot in HIV world in my work as an HIV provider. And we've been seeing additional instances of where it's important in the last several years. This is something, I'm just going to jump right in. This is not a new concept. This is something that's been described since the 1970s. There were really the rationale at that time was there was up to about 50% of patients with cardiovascular disease with no clear risk factor, and infections were seen as a possible, excuse me, source of that unexplained risk. There was a study in the 1970s in which it was demonstrated that germ-free chickens had developed typical atherosclerotic lesions when they were exposed to a type of avian herpes virus. I don't know how clinically relevant that was at the time, but it certainly was a seminal study that helped us consider that infection may in fact be associated with cardiovascular disease. There have been earlier studies that had demonstrated that cholesterol had also accumulated in the presence of this disease. So the model was set in the 70s. The 80s and 90s led to a lot of studies, kind of scattershot at different infections. The most commonly studied ones were CMV and chlamydia pneumoniae, also called TWAR. I hadn't heard that since medical school, but was reminded that that was what it was called often, especially when it was studied in this context. Some other random infections were studied at the time. And since then, there have been a number of other infections that have been looked at more closely. So the early studies were very crude, and it was very hard to tell what was just a correlation and what was actually a causation. One of the better earlier studies was done at Baylor, and what they were doing was looking at specifically at HSV 1 and 2 and CMV and its association with cardiovascular disease. What they did was they took 218 patients who, I'm sorry, they had 358 patients who had undergone vascular surgery for coronary artery disease. These were folks who they felt had who had demonstrated occlusions and needed intervention, and more importantly, had blood samples available. And they compared them to participants in a lipid research study, also at Baylor. who did not have a history of heart disease but did have lipid elevations. Uh, and what they did was basically look at titers of antibodies, circulating antibodies to CMV, HSV1, and HSV2. And you can see the very confusing results, but this is really what they were looking at. Among the patients who needed the vascular surgery, they tended to have higher titers of CMV compared to the controls. This study did not show any association with HSV1, but this is kind of how things started. Uh, for the purposes of this talk, I know there's a lot of different types of heart disease associated with infectious diseases. I'm not really going to be looking at long-term atherosclerotic risk. I know there's a lot of other, left ventricular dysfunction following sepsis. We're not so much going to focus on that. Uh, all right, sorry, there was a big flash of lightning right outside. All right, so over the years, I think the infections that we focused on have become more clinically relevant and less scattershot than, H. pylori here, Hep A there. We have the new epidemic of COVID-19 in the last 5 years that we know has cardiovascular complications. We've seen other bugs that have been around forever, TB, flu, sepsis. We have more information about that. And we have some old epidemics that have transformed over the years. I'm not going to talk about all of these, but I'm going to focus on some of them. All right. So again, the early studies really left a lot to be desired. The studies were mostly retrospective. They depended on serologies. Molecular studies were very limited, but became progressively more available. And again, there was this issue of demonstrating an antibody or even demonstrating the pathogen didn't necessarily mean that it was driving the process. But I mean, that's kind of one of the pillars of epidemiology. It's all about establishing a correlation. Causation is a little more challenging. Um, One of the things we did learn over the years is it seems that absolute infectious burden and cumulative exposure to infections may be a factor. All of the different studies at different organisms over the years kind of shifted our attention from, is there this one kind of quiet infection that is driving cardiovascular risk in people, to the idea that maybe any infection to some degree can cause progressive risk of cardiovascular disease. More importantly, I mean, all of this is very esoteric and academically interesting, but we are clinicians and we care about managing our patients, reducing their risk, and doing right by them. So what do we do about it is really the main question. How do we produce an intervention that can help, or can we? Now, in the early studies that really zeroed in on chlamydia, whatever we were calling it at the time, it's back to chlamydia pneumoniae, uh, focused on giving antibiotics. Lots of antibiotics must be a good thing, right? A lot of people think that in infectious diseases. We're not great believers in that mantra. As needed, not a drop more. Um, there were a number of initial studies, quite a few studies that showed mixed results with providing antibiotics to folks who seemed to be affected by chlamydia pneumoniae. Um, and as far as whether or not that reduced risk, it was a little bit confusing. Finally, there were two larger, well-designed, forgive me, randomized trials, both of them published simultaneously in the same edition of the New England Journal. One randomized to long-term gadafloxacin, one to long-term azithromycin, and there was no benefit. So kind of the studies that had been building up to that point dried up a little bit because the intervention aspect of it didn't seem as promising. We didn't see quite as much work for a number of years. Um, I'm sure all of you are familiar with some version of this figure, which is mechanism of development of atherosclerosis. I'm just going to kind of zero in on common themes that are going to come up just to keep in mind as we talk about these infections and the ways that they may cause risk for cardiovascular disease. So Endothelial cell damage, that one, sometimes direct, sometimes indirect, by the actual infection. A lot of them will upregulate cellular adhesion molecules. That is a common feature. Some of them will cause increased migration of activated APCs, including macrophages and dendritic cells. Um, we'll also see cytokine production, sometimes very exaggerated as a mechanism. Some infections, including HIV and CMV, will increase the uptake of oxidized LDL, and that will contribute. And then, for example, with COVID-19, exaggerated platelet degranulation and adhesion causing small clots will be a feature. And what seems to be a common thread is whatever the underlying mechanism is, eventually there will be kind of this vicious cycle of persistent inflammation uh, that drives itself and in some cases doesn't really settle down at all. All right, so I'm going to talk about sepsis first. This is something, I think it's not novel to say, sepsis causes long-term cardiovascular issues. Um, One of the things we've learned over time is that it's not just the immediate aftermath, that there does long-term seem to be increased cardiovascular risk, increased mortality risk. Uh, Most of the work over the years is focused on the first 6 months after discharge. It seems that this risk actually extends beyond that. Um, and we've had a better understanding in more recent years of what the long-term cardiovascular risk is. There's a great study in Taiwan that used population-based data nationwide, and they looked from 2000 to 2002, found all the hospitalized sepsis survivors, and matched them one to one to one of two different control populations. One was the general population, the other was hospitalized patients with a non-sepsis diagnosis. And they adjusted for a number of cardiovascular risk factors. They looked at mortality, they looked at major adverse cardiovascular events in different subcategories of those. Oh boy. I hope I don't lose you guys. It's getting ugly outside. Um, and what they found was significantly elevated risks in sepsis survivors. They found that these risks weren't just limited to the 6 months after discharge, after the septic event, but persisted for up to 5 years. So this was back in 2016. And you can see on the right the hazard ratios for the sepsis group at the top compared to I think that's the general population at the bottom, the non-sepsis hospitalized patients. You can see across the board, whatever the outcome is that they used, there is a significant difference. There was a study done in St. Louis more recently, a longitudinal study looking at this was a single academic medical center looking at risk of stroke, MI, TIA, and sepsis versus non-sepsis hospitalizations. They considered bacteremia and or sepsis, and they compared again to non-sepsis hospitalized patients and looked at risk of cardiovascular events over 5 years. They found in folks with bacteremia, it was one and a half, the risk was 1.5-fold higher. In any sepsis, not Jani sepsis, it was 2.39-fold higher, which is a little surprising. I would think bacteremia would, compared to any sepsis, might have a higher risk, but apparently that's not the case. That's why we do studies. And they found in patients who had septic shock, the risk of MI was almost 7 times higher over 5 years. Here are the odds ratios for the different outcomes and the different exposures, and you can see it's for any event, it's pretty compelling. Um, for stroke or TIA, it's a little less significant unless the severity of the septic event was higher, but for MI, it remained quite high. All right, and then there was another meta-analysis and review done in 2021 looking at over 12,000 citations for which they only came up with 27 studies. That sounds like a lot of work. 25 of these were cohort studies, and they compared septic patients to either non-sepsis hospital survivors or the general population, looked at MI stroke. They looked at congestive heart failure. Uh, And with the studies, you can see the sepsis survivors, the ends were in the thousands, the controls were in the tens of thousands. And what they found was an adjusted hazard ratio of almost 2 for MI, a little bit less for stroke, and similar for congestive heart failure. Um, and again, they looked at this over 5 years and found that these risks did persist. These are the different studies and the different outcomes, and you can see the trends on the right for the hazard ratios tend to be generally, they seem to tell a pretty consistent tale. So why does this happen? I mean, I think we know in sepsis that endothelial damage, at least in the acute part of the process, is a major problem, a major issue for why they become hemodynamically unstable. What seems to be happening is there may be an effect of premature vascular senescence that leads to the ongoing risk, which is to say endothelial cells uh, die prematurely and may contribute to persistent inflammation. There have been studies looking at persistent elevation of inflammatory markers. They've been inconsistent. Um, and then there was a study looking at procoagulant activity post-sepsis that may be involved. This was looking specifically among patients with sepsis caused by pneumonia. But the long-term effects are not terribly well understood. All right, so I'm going to talk about influenza next, largely because it seems like everybody in Richmond has had influenza in the last 3 or 4 weeks. Um, and major influenza public health questions seem to be on the immediate horizon with avian flu. Um, Surprisingly, long term, not a ton of data on this. The relationship, what our understanding tends to focus on the first 14 days after influenza event. Whoa, I'm very uncomfortable. So I apologize if I flinch every time there's a flash. Um, all right. The relationship's been described for over 20 years. There are a number of proposed pathways. They are familiar ones. They are vaguely described. They are what you probably would sit down and say, well, I think this is probably what's going on. If you had never looked in the literature, it has to do with destabilizing of plaques and activation of inflammatory pathways. There was a mouse model over 20 years ago that was done that demonstrated in mice exposed to influenza that there was inflammatory cell infiltration, smooth muscle proliferation, and fibrin deposition in vascular cells. And this sort of model has been pretty helpful over the years, so something to consider. One of the issues with influenza studies and cardiovascular risk over the years is the studies tend to focus only on very severe influenza, and it's not exactly clear what the risk is beyond the first 14 days in patients who don't have severe influenza. So this came out in September. This is a population-based self-controlled case series done in Spain using registry data. Over 2 million patients were able to be sampled from. And this study showed a doubling of risk in cardiovascular events in patients over age 50 with mild flu and minimal baseline risk. In folks who had severe flu and higher risk, the risk quadrupled. The risk remained doubled in those guys at 2 months. And unfortunately, the follow-up wasn't, again, not as long as we would love. Um, but anyway, this is one of the more helpful studies, one of the more recent studies as well. All right, now I'm going to dive into COVID-19, where in just 5 years, we have really accumulated quite a bit of data, a lot of it from just the early days that we were finally able to look at when the dust settled. I think everyone remembers this well. When folks were coming in initially to the hospital with COVID-19 pneumonia, it wasn't just pneumonia. It was almost like everything you can imagine besides pneumonia was going on. Young patients, older patients were having strokes, MIs, going on dialysis, having PEs. There was a lot of myocardial damage, and it was kind of hard to understand what we were seeing, and it was especially hard to understand what we should do. I remember we were at a large public safety net hospital in New Orleans, and some of the some of the not evidence-based interventions that were happening were a little stunning. Um, but again, no one really knew what to do, and the patients were so sick. So, in the beginning, I'm sure a lot of you guys remember this. Trying to get protocols through could be a challenge. I think our system evolved to that eventually. I suspect, I hope VCU did as well. Um, the number of cases you were able to get seemed to vary widely. With the waves of cases, is once you had a study design and were ready to and had it through IRB, all of a sudden there were no more cases. And when the cases came back, it was a new variant, and was not directly comparable necessarily to the previous wave. It was quite tricky. Adding to the confusion was these pre-review publications that were kind of flooding the airwaves, including um, the notable one that's been discredited and retracted about hydroxychloroquine. But there was a lot of chaos. Uh, there was one review. This was really terrific. These guys put this together by the end of April. That is really, really soon in the game, and they just went through the literature, the published peer review literature, just to describe what people were seeing. And to people's credit, these cases and case series were getting out there pretty quickly. There seemed to be patterns that were seen over and over again. And first is myocarditis or acute cardiac injury. It's folks who came in that something was not quite right. They didn't have an MI, but they had elevated troponins. So they didn't it didn't make a lot of sense, but they were sicker than they should have been. Then were the folks who had actual MIs. There were arrhythmias, cardiac arrest. We saw a fair amount of Takotsubo cardiomyopathy. Cardiac tamponade was seen. Certainly venous thromboembolism. Stroke is another one. So these are the main themes. I had to include this figure. This is one of the worst figures I've ever seen in a publication, but we had so little to go on back then. What they came up with for this publication was just a picture of a heart and some arrows with different pathologies seen with the incidents, and you can barely make it out in there. But nonetheless, this is a helpful review. I don't mean to make fun of them. They really did a great job. Uh, 5 years later, almost exactly 5 years as we are right now, the dust has settled a little bit. I think we know a little more about what we're talking about. And what we've learned is up to 20% of patients who are hospitalized with COVID had some kind of myocardial injury. It's been reported about 11% had an acute MI while they were in the hospital. There have been autopsy studies showing a different sort of thing than we might otherwise expect from just cardiovascular risk, but a lot of microthrombi. And this has been repeatedly demonstrated. A lot of patients who had STEMIs, a high proportion of them didn't have any sort of occlusion, which suggests there's more going on here than just plaques rupturing. Um, there was a study looking at increased risk of recurrent MI and planned revascularization and death in STEMI patients. They compared the pre-COVID to the post, February 2020 period and found that suddenly there was an increased risk of all of these things. Um, Very indirect, but it contributes to an understanding here. Over the years, there seem to be three main mechanisms that are contributing, and they're a little bit different than some of the other infections we've seen in the past and that we focus on in general. Endothelial dysfunction, platelet activation, persistent inflammation. We have I'll kind of walk through these because I think it sets the stage for future ways to help these patients. So what's been described as increase in endothelial dysfunction, it does seem to be perhaps differentially limited to some vital tissues, heart, brain, and lung. it hasn't been demonstrated if the virus itself is doing this. One thing that may be happening, it's been well documented that the virus interacts with ACE2. It seems to cause internalization of ACE2 and downregulation of it. ACE2 does have some immune modulatory effects, and that may be an issue. There also seems to be significant stimulation of the innate immune system, particularly with toll-like receptors that trigger the well-established cascade of cytokine signaling. Um, the virus itself seems to have its own distinct ability to upregulate nuclear factor kappa B, which triggers the whole IL-1, IL-6, TNF alpha that I think we're all very familiar with. The virus itself seems to cause unusually high levels of cellular adhesion molecules that allow white blood cells to infiltrate the endothelium. There does seem to be a distinctive increase in oxidative stress as well. This is a very generic picture that is just showing COVID potentially damaging the endothelium, and then a damaged endothelium activating nuclear factor kappa B, triggering the whole cell adhesion molecule and signaling cascade, leading to endothelial cell death and more inflammation, and then the vicious cycle. What I really wanted to focus on here, I find these figures to be a little bit confusing, but when COVID binds to Ang2 normally, I'm sorry, ACE2. ACE2 will cleave and form Ang1 through 7, which has the downstream immunomodulatory effects. This is really a very unique thing of COVID, and seems to be a big part of why we see so much inflammation. So I'm just going to focus on that. Platelet activation seems to affect patients with COVID-19 in a different way than some of the other infections. COVID seems to directly interact with the platelets, possibly even invading them. It seems to cause platelets dysfunction, causing them to just kind of roam around, die, empty their cellular contacts, and trigger more inflammation. But it also seems the virus seems to upregulate molecules that are involved in aggregation of platelets and interaction with leukocytes. The platelets also seem to be hyperactive, leading to a more exaggerated degranulation, which leads to increased vasoconstriction, more adhesion molecules, and an upregulation of macrophages. This seems to be a big part of the platelet activity in the microthrombi and some of the venous thromboembolism we see with COVID-19. Oops. And then there's the role of chronic persistent inflammation. This is a very common thread with most infections causing cardiovascular disease. Again, monocyte transmigration, transformation into macrophages, development of foam cells, vascular permeability, also kind of drives the processes we've already talked about: endothelial cell dysfunction, platelet activation. We talked about COVID triggering pattern recognition receptors like toll-like receptors. Another distinct feature of COVID-19 is the way it forms inflammasomes that drive additional inflammation, especially the NLRP3 inflammasome. And it does seem to be involved with cytokine signaling being amplified. So I'm not even going to try to go through this. I'm not sure how helpful these are. But you can see it's a lot of different factors. You can see the inflammasome in the top portion is this very unusual swirly looking thing that drives inflammation. All right. Treatments, what do we do about it? So that's the big question. This in just 5 years, this has been explored quite a bit. Unfortunately, the thing with this is it's been explored at the most basic levels. We're looking at pathways, very, very early on in the non-specific inflammatory pathways pathways like IL-1, IL-6. There does seem to be, some benefit to these in reducing cardiovascular events. There also seems to be some benefit to these in COVID mortality and hospitalization length. They really haven't been well studied in the context of COVID and cardiovascular disease, but they may have some promise in the future. They're so non-specific, one would expect side effects, and hopefully at some point we would come up with something a little more targeted. I mean, I would almost consider these the equivalent of treating, cancer with something like doxorubicin. It may affect the cancer, but it's going to affect other things as well. Colchicine is also something that's shown some promise. It does have there are descriptions of it downregulating the NLPR3 inflammasome, downregulating some of the adhesion proteins on platelets. All right, and let's talk about long COVID. There have been a number of cardiac symptoms described with this. Long COVID is often now called PASC or post-acute sequelae of COVID-19. Some of the most common ones described have been chest pain. You get the point, chest pain, palpitations, arrhythmias, clots. And why is this? Now, we talked about the acute process, but it seems that viral RNA and antigens, just remnants of the virus, persist. They've been described in different tissues, they've been described in feces as lingering for months. Now, their persistence may just be stimulating inflammation, leading to these symptoms. It doesn't appear that they're actively replicating. There also seems to be an association with levels of spike-specific CD4 cells. Levels of these cells do seem to be associated with the severity of the initial disease, but also have been correlated with long COVID symptoms. The other thing is dendritic cells, which are some of the antigen-presenting cells we see in the endothelium, seem to express the virus for months as well, which may lead to chronic inflammation, persisting in those cells. There does not seem to be persistent T cell dysfunction, which can be involved with persistent cardiovascular risk, and that'll come up a little bit later. This seems to get normal over time. There may be an autoimmune element. Anticardiolipin antibody, ANA, has been described in atherosclerosis in folks with PASC. There may be some ongoing endothelial dysfunction. Endothelial cells have been detected in the blood for months in these patients. And there has been demonstration of persistent elevation of inflammatory cytokines in the blood. All right, and my dog has joined us. This is just a list. Obviously, don't go through this, but you can see all of the different studies looking at risk of atherosclerosis in post-COVID-19 patients. For the most part, there is it's either post-COVID hospitalized patients or non-hospitalized or both compared to non-COVID-19. And for the most part, there is a significant effect. You can see one of the studies actually has a protective effect. The research question that they were asking was quite different. It was post-COVID-19 vaccinated versus unvaccinated, post-COVID-19 unvaccinated. And you can see vaccinated patients did seem to have a benefit, supporting one more reason to use this as a prevention strategy, or at least a protective strategy. Some of the take-home points I would just make sure are clear on this. In COVID-19, it seems to use well-known mechanisms for atherosclerosis, but they seem to be exaggerated. Thanks. Sorry, getting rid of the dog. Come on, go. Thanks, sweetie. Sorry about that. It seems one of the things we do see is anyone who's had COVID-19, whether or not they had high risk or low risk for cardiovascular disease beforehand, data suggests that their risk increases across the board, regardless of who they are or what medical problems they had previously. Some of the important priorities for us are going to be stratifying those at highest risk, to do additional workup to make sure there isn't higher risk or a pending ruminating more incident cardiovascular process. and to identify strategies. In just 5 years, we've actually come a long way. All right, I'm going to talk the rest of the time about HIV and cardiovascular risk. I'm going to zip through this part because there really is a lot of material here. So this is probably the infection that's been most studied over the years regarding cardiovascular risk long term. This is something we had a late jump on because patients with HIV for the first 20 years of the epidemic didn't develop cardiovascular disease, right? Maybe the first 15 years, I should say. It was, as a lot of our patients say, a death sentence in the early years. 1996 was when the cocktail, the three drug therapy became standard of care. Even though the drugs were very harsh at the time, they've become progressively much easier to take. Uh, the dosing has been much easier, promoting adherence, and they become more potent. So this has allowed for chronic disease to develop in HIV patients where it wasn't before. And what causes mortality in HIV patients has changed a lot. Now, this is a study from um, 2014 from France looking at mortality causes in HIV patients in 2010, which is the top bars, in 2005, which is the middle dark bars, and then 2000. So these data are probably already obsolete, but you get the point. You can see AIDS, the proportion of AIDS has gone way, way down. And then the proportion of non-AIDS malignancy is up, cardiovascular disease is up, other, non-AIDS conditions is up. The point is they're not dying of opportunistic infections and AIDS-defining cancers anymore. It's the stuff that everybody else dies of. Um, and that's because one of the reasons, one of many reasons that we're going to talk about is they're developing risk factors. They're developing comorbidities. One of the things we've learned about risk factors for cardiovascular disease in patients with HIV is that they seem to develop earlier and they seem to be more common than in patients without HIV. And this includes the usual suspects: hypertension, diabetes, hyperlipidemia. For a number of reasons, tobacco use disorder is much more prevalent, usually across the board in people with HIV. Uh, and Studies have shown, independent of this increased prevalence in risk factors, HIV itself also seems to have independent risk for cardiovascular disease. So even when you control the risk factors, the risk is there. Even when you control the HIV, the risk is there, as we'll talk about. Um, Summary: HIV patients seem to have about twice as much risk for MI and stroke as comparable people without HIV. This is a publication from 2011 that just also probably obsolete, but I suspect is very similar if you were to do a similar study today. Um, Prevalence of significant comorbidities in people with and without HIV as they age. And you can see, the divergence is very slight for some of these, but for renal failure, for example, in diabetes, it's more pronounced. I suspect for diabetes, it may even be more pronounced currently. Um, One point I would make as we continue is HIV. A lot of folks think of it as when you have HIV, your immune system stops working, you become at risk for infection, and what you need to do is restore that immune function, and then your risk will go away. It's a lot more nuanced than that. HIV is really a dysregulation of the immune system, and you can make a lot of that dysregulation go away by controlling the viremia with antiretrovirals, but you can't make it completely go away. Um, all right, I'm going to talk briefly about the SMART study, which was published in 2006, but was a very seminal piece of research in understanding cardiovascular risk in HIV. What this did, so remember at the time, the drugs were very harsh. You had to take a lot of them. They had a lot of side effects. And that affected adherence. It affected their ability to suppress the virus. And that increased risk for developing mutations. So it wasn't a given that giving the medication constantly was a good thing. It really wasn't until about 2014 that we did this for all people. So this was a study that looked at, it compared uninterrupted ART therapy, which was the standard of care at the time, to episodic use of ART. When a patient reached a threshold of 350 CD4 cells, they would stop. And if they had symptoms of HIV disease or their CD4% dropped, that should reach CD4%. If it dropped below 15, they would restart. And they were randomized by a clinical site. The main endpoint was new or recurrent opportunistic infection or disease or death from any cause. But more relevant for this discussion were some of the secondary endpoints, which included cardiovascular disease. So these were the two groups. On the left was the intermittent antiretrovirals. On the right was the continuous. This is a bit of a confusing figure. Where you want to be in either of these is in the left cluster of low CD4 and have a high light bar. So low CD4, I'm sorry, high CD4, low viral load. You can see the folks on continuous therapy had this, but you can see the folks on intermittent therapy most definitely did not have this. They had lower CD4 counts and higher viremia. So that we need to just set that understanding as what was going on with their HIV. We looked at the secondary endpoints. I say we, I wasn't even in med school at the time, but focusing on cardiovascular disease here. And we saw that the folks in the continuous therapy group had a much lower risk of developing cardiovascular disease. And you can see this is when cardiovascular disease is lumped in with renal or hepatic disease over time. This was the only figure they had available, but you kind of get the sense that the folks who were on antiretroviral therapy had lower risk of developing other comorbidities. So to complicate our discussion, over the years, certain antiretroviral drugs independently increase cardiovascular disease. These are medications we don't use so much. Lopinavir, ritonavir was a protease inhibitor combination that has largely been scrapped, used for salvage therapy, if at all these days. Abacavir is one that, to this day, we don't really have a smoking gun that it causes cardiovascular disease, but there have been repeated studies that trend towards significant risk for cardiovascular disease, and a lot of providers have just stopped using this altogether. All right, so I'm going to talk just briefly about this idea of residual immune dysregulation syndrome, which is the idea that even if you have sustained virologic suppression in HIV, you're going to have increased T cell activation, elevated inflammation, coagulation, which is not completely erased with suppression. So again, HIV infection is a dysregulation, not just a loss of immunity. Clinical associations that have been shown include cardiovascular events, liver disease, metabolic disorder. You get the idea. The proposed mechanisms for increased cardiovascular disease are all over the place with HIV. We know there's viral persistence. This is why we can't cure HIV. It persists in a reservoir of macrophages that are, one of the prominent immune cells in atheromas, involved in IL-6 production. It does seem to increase cell adhesion molecules, does seem to induce endothelial apoptosis. There's stimulation of both the adaptive and innate immune system. The persistence of co-infections that travel with HIV is thought to be an important part of this as well. Part of gut translocation sort of piggybacks on that, in that organisms in the gut may be, translating into more systemically and stimulating immune function. This is just a modified version of that COVID fit picture. It's a picture of a heart, but all of the different factors that come into play with HIV infection contributing towards cardiovascular disease. Risk factors, medications, co-infection, a number of different factors that can stimulate chronic infection. This is another overwhelming picture of inflammation, but just the top part, A through F, I think are very helpful. These are some of the topics we talked about before. Increased T cell activation. We said this does not seem to be involved with COVID. It is most certainly involved with HIV. Increase in cell adhesion molecules. dysfunctional cholesterol efflux into endothelial cells, dysregulation of the endothelial junctions, and priming of inflammasomes that further drive inflammation. So the question was asked almost 20 years ago, what do we do about this? And can we even describe what the risk is? Do we even have the tools for that? And for a long time, we didn't. So when they modified the guidelines for how to manage cholesterol about, I think it was 11 years ago, I want to say, there are a lot of different decision points. What is the patient's age? Do they have diabetes? What's their LDL, et cetera, et cetera? What is their ASCVD a risk score? But HIV never figured into that. HIV was kind of lumped in as one of these quote unquote risk enhancers. And there was a little bit of hand waving involved when it came time to make a decision on how to manage this. The guidelines also had this separate separate box for chronic inflammatory enhancers that included HIV. It was sort of lumped in with rheumatoid arthritis, um, you know, with not terribly strong level of evidence. And that's kind of what we went by. So if folks were kind of close to needing a statin, we might put them on a statin, but there was no hard and fast rule. And then there came the Reprieve trial, which went on for a number of years. So this was published in the spring of 2023, and it really changed the way we think about this. Funded mostly by NIH, there was a little bit of contribution by pharma. Um, and the rationale for this was we know there's increased cardiovascular disease in HIV patients, and that includes younger people. And we don't have much data to go on to intervene. Now, there's probably something we can do. We know statin therapy does have some immune modulating properties. Might this be a benefit for people with HIV to prevent cardiovascular events? So pitavastatin was chosen as the intervention. It was chosen over the other statins for a number of reasons, but most importantly, it did not have drug-drug interactions with HIV, ART. Um, excuse me. Population was similar to that described in the ASCVD calculator group. Um, Folks 40 to 75, they had to be on stable ART, I want to say, for 180 days. And initially, it was just folks with an ASCVD risk over 10%. And they had a hard time finding patients to be in the study because so many providers had already just started these patients on statins, uh, anticipating that their risk was somewhat elevated. So over time, they expanded the group and it went down to folks with less than 7.5 10-year risk uh, of ASCVD, as long as their LDL, I think, was over 190. Um, and that proved very important when the findings came out. So you can see the exclusions, folks we knew had cardiovascular disease or had been using statins. And they were randomized 1-to-1 pitavastatin versus placebo and stratified by a number of different factors, HIV factors, demographic factors. Everybody was given lifestyle modification advice and the usual change in treatment per their provider or study investigator. They looked at major adverse cardiovascular events defined this way. Secondary outcomes were different combinations of major cardiovascular events, lipid targets, death from any cause, safety events. And the statistical considerations, I'll put this out here, they did it this way, and they had a couple of uh, interim analyses by the Data Safety Monitoring Board at 50%, 75% of predicted outcomes. This is important because when they got to the interim analysis for 75%, they stopped the study because they found that there was significant efficacy of intervention, and it was deemed not ethical to proceed to give people placebo. They ended up enrolling almost 7,800 people. Here are some of the demographics. They were very well controlled HIV patients with pretty robust CD4 counts in general. Follow-up was pretty good. Adherence was pretty good. Discontinuation of the trial intervention wasn't too bad, very comparable. And the primary outcome, incidence of MACE, clearly elevated in the placebo group. The hazard ratio of 0.65 for pitavastatin. They did adjust the criteria when COVID happened. There was only one ischemic stroke attributed to COVID, but take home here was a 35% hazard reduction over an average of 5.1 years. Some of these patients were in the study for up to 9 years. That led to a number needed to treat over 5 years of 106 for folks who had increased risk for cardiovascular disease. The number needed to treat was quite a bit lower, depending on what that risk was. You can see, according to the different outcomes that were looked at, pitavastatin was favored in just about all of them. So here is the two groups over time with a cumulative incidence on the left of their first major adverse cardiovascular event, and then on the right, MACE or death. And then this is the breakdown by subgroup. And you can see for the most part, it favors pitavastatin. I'm going to break this down a little more specifically to their ASCVD risk score, because this was not, I don't think this was expected to the extent we saw this. This group of people with 5 to 10% 10-year risk had what seemed to be the strongest protective event. Now, these were a protective effect. These were folks who weren't even supposed to be in the study initially, but this kind of blew everybody away. I think we all knew more people were going to benefit by statin therapy with HIV, but I don't think we quite saw this coming. You can see among the intervention group, this is the effect of the pitavastatin group, the effect of pitavastatin on LDL cholesterol on the top, non-LDL cholesterol, non-HDL cholesterol rather on the bottom, that was sustained over time. There was an increase in diabetes incidence. I'll talk a little bit about this in a moment. A little bit of myalgia that was not, for the most part, significant. Very few cases of rhabdo. It was also seen in the placebo, so not a ton of concern about that. But yeah, the take-home 35% hazard reduction over the course of 5.1 years. It does seem, beyond LDL lowering, that there is an effect of the statins here, possibly attributed, like I said, to its immune modulation effects that have been previously demonstrated. And again, the shocker here is patients in that 5 to 10% 10-year risk of ASCVD. That group appears to have one of the strongest benefits from statins. Therapy was well tolerated, and what this led to is an abrupt change in the guidelines. So these are the NIH guidelines for people with HIV on antiretroviral therapy. These are supported by the ACC as well. And in this 40 to 75-year-old group, in folks with an ASCVD 10-year risk 5 to 20, they should at least be on a moderate dose statin. And it was expanded to atorvastatin and rosuvastatin, which seems to be pretty reasonable. In folks who, in this age group, less than 5% ASCVD risk, it seems reasonable to start at least moderate intensity statin. Less of a strong recommendation in folks less than 40 years old, insufficient data, but consider in certain populations. Now, in folks with greater than 20% risk, do high dose statin. If their LDL is higher than 190, high dose statin. And if they have diabetes, at least moderate intensity statin. Talked about the diabetes risk. I'm just going to kind of blaze through this. There was a follow-up study that came out in November. In short, I'm trying to say here, both the pitavastatin, this is a subgroup of the Reprieve study, both the pitavastatin and the placebo. The risk of diabetes was significantly associated with diabetes risk factors in both groups. It wasn't so much the pitavastatin as much as was feared. You can see that gray line at the top in both groups is those with highest number of risk factors. So you can see for both of them that stood out. And they looked at who had in each group, in the folks with new diabetes, major adverse cardiovascular effects, 1% in the pitavastatin group, actually a higher percentage in the placebo group. So the pitavastatin didn't seem to be driving MACE. All right, almost there, you guys. So because of all the work that's been done here, it's given us a kind of an insight into what the possibilities may be, not just for HIV, but for other infections. For HIV, we have a plethora of data here. So other interventions have been studied, some successfully, some less so. Um, these are the categories of interventions that have been looked at. A lot of it is the same old culprits: IL-1 beta antagonist, IL-6 antagonist, TNF-alpha antagonist. Um, a lot of work yet to be done. Aspirin, no compelling data so far. The recommendations for aspirin in HIV patients is the same as folks without HIV. Um, So this has become a big focus of HIV management. We don't worry so much about suppressing the patients anymore. That used to be our entire job, was finding the right regimen for each patient with HIV. Now we do a lot of managing their chronic disease risk. So we aggressively screen for other cardiovascular diseases. We do annual lipid screenings. We do lipid screenings after they start antiretroviral drugs. We look at A1C when they're diagnosed, but it's hard to use because antiretroviral drugs will bias it downward and make it appear to look better than it actually is. We get them on treatment quickly. As soon as they're diagnosed, we try to link them to care, get them on medicine within 7 days. We're aggressive with immunization, flu, COVID, and a lot of other things. You can probably understand why. We're very proactive in trying to get them to quit tobacco. There's a lot of proactive prescribing of varenicline. Varenicline's been added to state AIDS drug assistance program formularies, Ryan White formularies, to make sure patients, regardless of their insurance situation, can have access to them. And there's a lot of focus on weight management, including a new recommendation for annual waist circumference management. All right, so let me just kind of go over the take-home points here. Again, many common infectious diseases appear to create cardiovascular risk over the long term. A lot of hand waving still, not a ton of specifics. I think COVID and HIV are the outliers. Um, both of them are interesting in that for HIV, this understanding has happened in a relatively condensed amount of time, and for COVID, certainly a condensed amount of time. Um, we have a lot of potential to collect data, to synthesize it, and direct research. So hopefully we will have more interventions for these problems in these conditions. The answer probably is not more antibiotics. I'm just going to throw that out there. Um, get people with HIV on antiretrovirals, but they're still going to have a disproportionately elevated cardiovascular risk compared to people without HIV. Um, we have a good target. So HIV has served as a model for some of these other infections. All we have to do is, research them as much as we've researched HIV, which has been relatively richly funded over 40 years. And now basically everybody with HIV over age 40, more or less, should be on a statin. Um, we made it to the finish line. Here are the references, and I'll take any questions you might have. Thank you.
Oh, thank you for the great talk, Dr. Binani. Yeah, this was truly remarkable in the lecture with lots of learning. I'll now start taking questions from the audience, but we don't really have a good amount of time. So if there's any direct questions from the audience, I'll take it.
There's one in the chat, Tishik, from Dr. Hayter.
Right, yeah. So there's one question from the Aga Haider. Should statins be started in moderate or greater um, coronary artery disease risk patients with acute COVID infection or long COVID?
Wow, great question. To my knowledge, there's no specific recommendation to do that. I know people who have done it. I don't think that we can speak to that at this point. Um, but I know I've seen that done a lot. Um, now, is there evidence to back it up? Not yet. It is a consideration. Great question.
Hey,
Yeah.
Dr. Bennani.
Good morning.
Go ahead. Go ahead.
Hi, my name is Aditi Patel. I'm one of the cardiology fellows. Thank you for your great talk. For clinical practice for patients who are on heart therapy, some of the recommended guidelines include a little bit more frequent cardiac risk stratification labs. So, A1C, lipid panel, just because even though the immune response secondary to the HIV infection is tamped down, the drugs themselves also can lead to increased atherosclerotic risk. Where do you kind of see those guidelines going, and how do they counteract the atherosclerotic risk that is inherent from HIV infection itself?
Great question. I can tell you the standard of practice has evolved a lot just in the last 3 years. We've had major guideline changes twice in the last 3 years, including most recently in October, specifically addressing these issues. I think for now, again, the latest guidelines are just a few months old. I think we probably with lipids, I mean, we're going to have so many patients, and we already do on statins. Um, I think the lipid screening is going to be at least every year for the foreseeable future for everybody. In the past, it had been if they were at normal, quote unquote, normal, what was normal before, ASCVD risk, it would be every 5 years, but now it's every year. I think one of the hot topics now is diabetes incidence in the current wave of integrase inhibitor drugs. And I think we know there's risk of weight gain that's clearly demonstrated. There does seem to be a less well-described risk of diabetes incidence. I think those guidelines are probably going to evolve in the next couple of years, if not sooner. There's no, equivalent of reprieve for diabetes at this point. Everyone's kind of known reprieve was, kind of simmering in the background all these years, and we couldn't wait to see what it was going to show us. But uh, I suspect that'll be the next change in the guidelines.
Hey, what's the role of the high dose flu vaccine in preventing cardiovascular disease? Is that sort of fallen out of favor?
Well, right now, I can tell you we use it again only in folks 65 and up. It's not recommended necessarily for cardiovascular disease in anybody else. And I think the reasons we're giving in 65 and older aren't so much to prevent cardiovascular disease. I think that's part of the calculus. I think part of it is immune senescence as well, and needing a bigger stimulus to generate a comparable response. But I definitely recommend getting your flu vaccine to minimize cardiovascular disease, and I recommend it for all our patients. Good question.
Thank you.
All right. Thanks for the excellent lecture and question sessions. It's a great pleasure with you, Dr. Bennani. And as it is past 8:30, I'll conclude the grand round lecture here. If you have any questions, or please send them via email, and I'll be happy to deliver him to the questions, including ones in the chat window. Yeah, actually, Dr. Patel just asked it. So thank you, everyone. There's a last slide. You can text it on this number to get a CME credit. Thank you.
Thanks, everybody.